So, welcome to a special episode of CRST, the podcast. In this episode, I'll be chatting with a panel of world-renowned surgeons about some of the exciting treatment options for patients with presbyopia. Joining me today are Amir Hamid from Optegra Eye Hospital in London, Sri Ganesh from Netradama Super Specialty Eye Hospital, Karnataka in India, Joaquín Fernández from Q-Vision, Almeria, Spain, Erika Eskina from Eye Clinic Sphere, Moscow, Russia, and I'm Beatrice Cochener from University Brest Hospital in France, your host for today. We'll be discussing things like IOL technologies for presbyopia correction, considerations in post-refractive surgery patients, and matching the procedures to the patient need. We'll also talk about good ways to educate presbyopic patients on the available options. So let's get started with sharing our preferences and experience with presbyopia corrections. So about surgeons' preferences and experience, I would like to ask you guys, what about corneal options when we think about LASIK versus PRK versus blending vision versus monovision? Erika, would you like to tell us what you think about these different options regarding presbyopic correction?
With a pleasure. First of all, we are watching at the patients and we decide what is better for the patients regarding the approach. Is it PRK or the LASIK or femto-LASIK or even SMILE sometimes, but it's just a way to correct the refraction error. And then we are talking about the approach which we use to correct presbyopia. And this is a challenging group of the patients, and they take from us much more time than a regular patient to discuss their expectations, to check their tolerance to anisometropia, to check the aberrations of the cornea and the eye. And the most important is to check their expectations. And this all influence our common decision, because it's not a decision of the surgeon. It's a decision of the patient and the surgeon. This is my opinion. And of course, sometimes we decide in a direction of monovision, sometimes in a presbyopic corneal approach. And sometimes we prefer to reach the maximum result to any distance, to far or to near. And again, it depends on the situation.
Thank you, Erika. What about you, Joaquín? Maybe you make a difference if the patient is myopic or hyperopic to take your decision regarding, again, blended vision versus monovision?
Yes, we have to make very easy in our algorithm is based in two cut-off point in terms of safety and in terms of efficacy. In terms of efficacy, our cutoff point is about the double pass technique. In the past we call the OCAS. Right now is HD analyzer. You did an excellent work. At least you published an excellent cutoff point in terms of cataract of surgical criteria. And we published last year a review talking about the cutoff point of 1.5 of OSI. This contrast sensitivity that we are going to achieve with any multifocal lens is going to be better than the crystalline of the own patient. This cutoff point for us is very important. So below this cutoff point, we suspect, well, we can take consideration of a transparent crystalline, and we're going to a FRCOphth procedure. And with above this cutoff point, we are thinking about a intraocular or a pseudo-FRCOphth procedure. And in terms of safety, we can read in the journal Eye, a very interesting systematic review talking about the relative risk of operate on crystalline. When we have axial lens below 23 millimeter, we are not going to improve the relative risk of the retinal detachment. But when we have axial lens above 23 millimeters, we could improve the relative risk of retinal detachment overall 26 millimeters. So I think we have to take advice of that. This cutoff point, for my humble opinion, is very important to take in account.
I absolutely agree. And this is why we try to postpone the refractive lens exchange in the myopic cases as long as it's possible, and to find the corneal solution for them or phakic IOL.
I mean, you're making a good point. So before we move to the, I would say, the discussion on IOLs, can we again focus on these corneal approaches? And can you just, for our, attendees, just to mention regarding your experience, if you go for a monovision or if you work, using this blended vision, which is an interesting option to do what we used to call the presbyopia-correcting. So maybe both of you can make a comment before we go for this spotlight on IOLs.
If it's possible, I will start. The monovision, unfortunately, is an approach which provides us a limited in time result. So, and this is the topic we have to discuss with the patient. If he accepts it, and if he prefers to get the high vision acuity as a result of the surgery, but the limited in time result, then of course we are moving in this direction. But as well, patient is not able to decide by himself because he's not experienced and understand what can we offer him after the surgery. So my goal is always to try to show the patient what he will see after the surgery. So unfortunately, we are limited with simulators of the potential vision at the moment, but I hope it will be developed soon. But nevertheless, there are contact lenses existing and presbyopic multifocal contact lenses, and we definitely try to show patients different options.
Interesting. What do you think, Joaquín, about this? I mean, this way of using the contact lens test before?
Well, I really appreciate this information. It will be very interesting. The more we involve the patient in the shared decision making, the bigger is going to be the satisfaction of the patient for sure. So I absolutely agree with these possibilities. In terms of what procedure what we use, Beatrice, we recently, this week, we published in journal Cataract Refractive Surgery a review about how to manage the spherical aberration for the procedure. I think it's very interesting. And I think it's very dependent of the previous spherical aberration of the patient that we need to measure. And of course, the pupillometry of the patient. These two issues is going to be very important in the outcomes. We don't have good evidence enough about that, okay? We need to improve the design of the papers in the future to know, and even to improve trials with control group in order to discriminate the value that we could give to our patient. But these two issues is going to be very important. And for us, it's also very important what is the amount of dry eye, the ocular surface of the patient. If we have a not very helpful ocular surface, we go to a smile monovision. If we have a healthy enough ocular surface, we could think about a presbyopic option. Okay, so this is more or less the idea that we develop. But for sure, presbyopic for us is a good option for this if we could select the perfect patient and a healthy surface for our patient.
We understood finally that there are these two key options, I mean, the intraocular approach and the corneal one. So I was wondering, with your experience, Amir, if maybe you can make a comment between the choice of presbyopic versus some other trifocal IOLs. I know that you have a good study conducted in that comparison. Can you maybe tell us about the outcome of it?
Beatrice, thank you very much for having me here. I'm very happy to answer that question. Yes, we looked at our cohort of patients in a prospective way. Patients who had presbyopic laser blended vision, bilateral trifocal intraocular lens implantation and bilateral EDOF lens implantation. What we found was across the board, all the patients were happy, regardless of what group they were in. But for certain types of patients, they tended to be happier with a particular procedure, depending on their characteristics. So as a result of that, we developed what we simplistically call the presbyopia decision tree, depending on the patient's refraction, their age, their accommodation, and the clarity of their own crystalline lens. As a result of that, in my own practice, I tend to prefer, if they fulfill the criteria and able to tolerate monovision when we do our refraction, to default to presbyon laser blended vision, if at all possible. If not, there are other solutions which are just as good for these patients as well.
That's interesting. What about you, Sri? I mean, do you have any decision tree that you follow to make a comparison or decision between, I mean, in terms of age or in terms of accommodation? We heard that from Amir, to discriminate the intraocular and the corneal approach?
Again, depending upon the age, I prefer to do presbyon for the younger age group between 40 to 60 years and above 60 years also. I don't totally rule out presbyon, but I definitely would like to look at the crystalline lens, and I do some tests. I do I check the DLI, which is the dysmorphic lens index, with the eye trace and look at the score. And if the dysmorphic lens index is less than 5, then I would probably prefer to do a multifocal IUL. I also look at the OSI, that is the objective scatter index from the HD analyzer, and if the score is more than 1.5, then I would lean towards doing a trifocal IUL. Otherwise, I would prefer presbyon. And we also do the test, whether the test for dominance, the acceptance of the 1.5 dioptrad, whether they're able to accept the anisometropia and they do not have any cross blur. And if all the tests are suitable for presbyon, then I prefer presbyon. But in the old age group, definitely if there are some early lens changes, I would favor the trifocal IUL.
That's interesting. That, I mean, in full accordance to what actually Joaquín told us about the selection regarding the crystalline lens grading. I mean, we are all talking about mini monovision. We are talking about presbyon. Do you think that there is a better indication for presbyon for hyperopic patients rather than myopic? Do you manage these two categories differently in your experience, both of you?
Not necessarily. In our experience, we have found that the patient satisfaction is quite good, both for hyperopic and for myopic patients, and even some of the ametropic patients, some of them we have treated with presbyon. If the patient has an understanding about what to expect and how the presbyon works, wherein the dominant eye is corrected for distance and the non-dominant eye for near, and there is a blend zone between the two eyes, and they should not compare each eye. That is most important. And these patients are happy. For the hyperopic patients, we like to slightly overcorrect on the addition. I generally like to have a 1.75 add in the non-dominant eye, because we find these patients, especially the higher hyperopes, they have a tendency for regression because of the epithelial hyperplasia that happens because of the ablation pattern. And then after some time, they find their reading is not so good. So I would like to kind of increase the add, if they're tolerant to it, to about 1.75. And of course, for the myopic patients, you have to be on target for distance for the dominant eye. And we don't find much of regression in the myopic patients, and they're quite stable. The very low myopes, the 1.5 to 2 diopters, you have to be a little careful, because their satisfaction is less, because they have a tendency to remove their glasses and read. So they have excellent reading, binocular reading without the glasses, and the distance also is good with glasses. So their expectations are a little higher, and they take a little more time to adapt. So you need to kind of counsel them, and you may probably have to spend more chair time with them.
Absolutely. I get that you do agree on that, Amir. What do you think of the myopic patients? Are you doing SMILE, for instance? Because I was wondering if there is a place for pure monovision using SMILE or regular LASIK, or if you use presbyon in myopic patients?
So we do. So to the first question, I agree with everything that Sri said. I think the crucial thing, obviously, is patient assessment, patient selection, and very importantly with presbyon, regardless of the patient's refractive status, is the patient counseling, both pre and post-operatively. That is what delivers the highest level of patient satisfaction. We do to the second question, we do also do monovision smile, and patient satisfaction is also very high in that group. The only difference would be is that there is no blend zone currently in the way when I do monovision smile. So there will be some patients who their own innate accommodation isn't as great as others, where they will have a loss of intermediate vision from monovision smile. But having said that, the great majority of the patients that you treat with monovision will also with monovision smile will also be quite happy.
I would add to this discussion, sorry, Beatrice, that we made a study about how the dry eye of the patients influencing the speed of the brain adaptation and the vision recovery speed after presbyopic approach on the cornea. And unfortunately, especially in women, in females, we see a very strong influence of this situation. And our rule now that we are preparing our patients before the surgery, because this presbyopic surgery is very special. Patients are able to wait until they are coming to the certain condition when the treatment is more effective. It's not an urgent surgery. It's not a young patient which wants to get his result tomorrow. They are more wise in a way, and we use it convincing them to prepare to use the lubricants before the surgery, to correct their diet, to correct their skills of meals and behavior at the house. I mean, humidifiers and so on, to prepare them to get a better result. And it works. So collaboration with the patient is very important.
So information, selection are the key for success. And thank you for making this highlight on ocular surface, which has just become with the time one of the most hot topic, I would say, that we need to discuss before. So we look very much forward to reading your 2 articles, guys. So thank you for all this good science. So regarding now the option that we just have today in terms of IOLs, I would say that some of our colleagues can even get confused with so huge and large offer in terms of optics. So maybe can you give us your experience and some tricks that you may use to select the proper technology depending on the patient? So in other words, how do you make a difference between trifocal, EDOF, or this new category of advanced monofocal? So maybe ladies first, Erika, if you want to tell us how you make your selection.
Yes, of course, I would like to share my experience. Unfortunately, in Russia, we're a little bit behind with the registration procedure. So something is not yet available, but still we have, of course, multifocal lenses and EDOF lenses, and the lenses with additional spherical aberration, I would say improved. And we are talking, of course, about the Zeiss lenses. And of course, the complete and sorrowful diagnostics before the surgery is very important. I would say that to convince our audience to measure the spherical aberrations in cataract patients, it's not easy. And unfortunately, sometimes we see that it is not taken into account, choosing the EDOF lenses or improved monofocal lenses. This is very important. And also, if we are talking about the type of refraction, I am sure that colleagues will support me, but hyperopic patients are mostly more happy than myopic. And I would again switch to the psychology. It's from one side surprising because hyperopic patients, they're normally very precise, very perfectionists, and expect from them that they will be happy from the surgery is not easy. But they are really happy from the multifocal and EDOF lenses, and the myopic are not. And I think it's a question also of their retina density in the macular area. And we all know that the receptive fields of the myopic patients are having different properties in comparison to ametropic and the hyperopic. And this is what we have to study and explore. This is my opinion. It's just a start for the discussion.
Yeah, I mean, I would say that it's very interesting to start with these kind of comments. Do you think, Joaquín, do you think that the myopic patients are maybe also less or more demanding for near compared to the hyperopic patient? That may be also another reason. What do you think, Joaquín, and how do you make your choice and your selection of IOLs depending on the patient's profile?
Well, Beatrice, I think that right now we have, as you said, a huge portfolio of intraocular lenses. First, I think we have two mandatory tasks for this presbyopic surgery. First of all, is have a very deep knowledge about each lenses, very deep knowledge. We need to know everything about that, coming from the optical bank, of course, from the papers, from the clinical. But overall for the young surgeon that want to get in deep in this type of surgery, the most important is what not to do, what not to operate is very important to have succeed, to have very satisfied patient in order to have ambassador of our practice, okay? So if you want, I take your issue in talk about this, what not to do. For my humble opinion, what not to do is not operate in transparent crystalline. Remember this cutoff about 1.5 OC with the HD analyzer. But the harder, the more opacification of the crystalline, the happier is going to be our patient because they are going to compare the quality of vision, okay? This is one of the most important. And of course, it's very important to take care about, for example, these different type of patient. Emmetropic patients are very dangerous. Emmetropic patients for sure are very dangerous. And probably myopic patients because of they have an incredible near vision and they could remember this situation, okay? But for sure, the better option to begin with this type of lenses is this type of patient that is hyperopic. They have lost 1 or 2 lines for distance and they don't use any glasses. This is the perfect option to begin. And overall, if they have a cataract and they have a healthy eye.
Absolutely. I mean, Sri, we know that you are living in India, and in India, you may have some experience with the phakic, presbyopic IOL that the entire world are so much looking forward. So do you have any experience in that new procedure?
I basically do not have too much of experience with the phakic presbyopic lens, because what I find with the phakic IOLs is there is an image magnification, and most of my patients, almost about 65-70% of my phakic IOL patients have improvement in their best corrected vision. And the phakic IOL, when you put the phakic IOL for a myopic patient, you have, because of the magnification factor, you have better reading. So what I find in the pre-presbyopic or the early presbyopic age, even if you do a full correction with the phakic IOL, they are somehow comfortable to read. And I've been doing phakic IOLs for nearly 20 years now. And many of my patients, earlier patients, highly myopic patients, have become presbyopic. I find that they don't need reading glasses. They're still able to manage reading glasses, because I think the optics are a little different. The cornea is a high plus power lens, and the phakic IOL is a minus lens. So there is some kind of a Galilean optics there, which gives them some amount of magnification. And because of this magnification, they have an improvement in best corrected vision. And for reading also, their angular magnification is better. So they are able to manage. For presbyopic patients, what I do is I do a mini or a micro monovision of half adapter or 3/4 of adapter, leaving them myopic in the non-dominant eye, and they're very comfortable. If you put in a presbyopic phakic lens, either a refractive or diffractive, then they have night vision issues. So somehow I'm not very partial to the presbyopic phakic lenses. I would rather do a mini monovision with a phakic IOL, and these patients are extremely happy.
I must say that I share your opinion in that regard. And we still don't know, I mean, at that age, if using a phakic IOL or in a patient of more than 45 years old, we may accelerate the occurrence of the cataract. So we still need to answer that question. So coming back to you, Amir, I mean, we have a large range now of available so-called premium IOLs. And I'm afraid that many of our colleagues can actually get confused between making a choice between a trifocal, EDOF, combined, a multifocal and EDOF. Can you maybe help us to clarify the situation and how you manage the selection of your patients for one category rather than the other?
Yeah, I think that's a really good question. I think particularly for people who are first starting out in this type of surgery. What I would say to reassure everyone is whatever platform you do choose from whatever manufacturer, the choices that we have now are of such high quality. It's very rare that you get an unhappy patient because of the technology. And it would usually is due to patient expectation rather than technology itself. As I discussed earlier, we do have the presbyopia decision tree even with regards to our IOL approaches. So that would depend on the degree of spectacle independence the patient is wanting, the level of night driving they do, how much close work they do throughout their day. And these are the things that we ask them when we go through our assessment with them. It's really important, despite having all these options that we have, that we explain to them from the start that whatever we do, there will be some level of compromise. And it's which level of compromise that they're most comfortable with, depending on their activities of daily living and their visual requirements. And that's how we would approach it. The patient that wants the greatest degree of spectacle independence will be offered a trifocal lens, but they have to accept that there will be some level of night vision disturbance, which they will take time to adapt to. And if they're willing to compromise on some near vision and occasionally wear reading glasses, EDOF lens would be better for night vision issues.
You're making a good comments, but I think that it's interesting to go deeper inside these topics of patient's expectation and compromise. That's definitely the two key words. But frankly, between you and I, when you discuss about patients' expectations, patients just would like just to forget about the eyes. And so not to think about, I think that all of us are using our eyes at all the different distances. And we don't know any patients who will just ask for reading or for far. So how do you manage that? Eskina, on your side, what kind of recommendation and what kind maybe of specific, I would say, characteristic or comments coming from the patient you would take into account for making your selection, beside the age, I would say?
I basically do not give the choice to my patient because they technically don't know anything about the lenses. So if I talk to them about EDOF or of trifocals, then they don't know anything about it, and they would not be in a position to make a choice. I make the decision for them depending upon their lifestyle. I also look at the height of the patient, the arm length, the reading distance, and I also ask them some questions about their lifestyle, about their hobbies, and about their driving, if they drive at night actively on highways. And if they are actively driving on highways, if they are taller, they have a longer arm length, then I'm more partial towards the EDOF lenses like the AT-LARA. Also, we take measurements of the angle alpha, and if the angle alpha is slightly larger, then I prefer an EDOF lens like the AT-LARA because the central zone is larger, and these patients are happier with these lenses because the central zone for distance is much larger. If the patient wants extreme close-up reading, if they have a lot of small print to read, and they're not driving much, then I would prefer a trifocal like the 80 Lisa, and that would give them a good vision for distance, intermediate, and near. And of course, they would kind of get adapted to the night vision issues. So basically, I use both, and sometimes I do mix and match. And if I mix and match, then I would like to use the EDOF in the dominant eye and the trifocal in the non-dominant eye.
Do you agree on that? I mean, are you dealing with mix and match also on your side, Amir?
I personally don't do mix and match, but that could be because of the patient demographic that I treat. They very much would like to know what lens they're going to have. They would have researched everything already, and sometimes bring research papers into clinic and things like that. So I think it's important, like Sri says, to understand your patients, and depending on that, you have to be flexible. And I agree with Sri. We often have to guide our patients to the right decisions in a way that will benefit them the most.
So, guys, we are all talking nowadays about this new third category, so-called, I would say, monofocal plus or advanced monofocal. What do you think about this new category? Do you think that it may take the place of the regular monofocal, or even maybe the place of some, potentially some EDOF lenses? Do you have some ideas about this new, I would say, option that is offered to us? Who wants to comment and to start first? Maybe Sri?
Yeah, I have had some experience with these lenses, and I use these lenses, the advanced monofocal lenses. Basically, they increase the depth of field slightly by about 3/4 of adapter, half adapter to 3/4 of adapter. So they're not really good for reading. It's an in-between lens. And what I find is that there is a little bit of compromise in the distance vision. The distance vision drops slightly. These patients, they can read 20/20, but not better than 20/20. And many of my monofocal lens patients, if their maculas are fine, many of them are able to read 20/20 or better with the aspheric lenses. So I think there is a little bit of compromise which you're not told about in order to get the depth of field, because physics is physics. 2 + 2 = 4. So if you're going to get something, then you have to lose something. So I feel that there is a little bit of compromise, but nevertheless, once you do both eyes and you have about 3/4 of adapter in both eyes, then there is some amount of summation, and these patients can probably manage intermediate vision. But what I find in India is that our pupils are quite small. So after surgery, the average pupil size is just about 3 millimeters, sometimes 2.5 millimeters. And this naturally gives an increased depth of field. So I don't find that these lenses give too much of an advantage, but maybe in the Caucasian eyes, which have much larger pupils, this increased depth of field may actually help them in getting some amount of intermediate vision over the regular monofocal lenses.
You're lucky, because in India, you may have this integrated Pinot lens. That is actually one of the very famous EDOF concept. So what do you think, Amir, about this, again, new category of advanced monofocal?
I think they're a very exciting new category of IOLs. It certainly expands the range of treatments that we can offer to our patients. Particularly in patients who are very sensitive to the possibility of glare and halos at night, but want some level of spectacle independence. The other group of patients who we could offer this lens to, and I have been offering this lens to, are patients that have, pathology. So they have some macular pathology or optic nerve pathology. So they do have some functional, spectacle independence without compromising too much on contrast sensitivity and impairing the visual function should their ocular comorbidity progress. One other thing that we've been doing, and this is an interesting thing that Sri has said, we've looked at our own case series of about 300 eyes now. We find that about a third of our patients, even if we aim for emetropia, will be able to read a newspaper quite comfortably. So in that patient population, what we've done in a group of patients, because of our experience with Presbeyond, is in clear lens extraction patients who don't want a diffractive lens, is we offer them a micro-monovision approach, stroke blended vision with an IOL. And that gives high degrees of spectacle independence without glare and halos, good levels of visual quality. So that's another approach that we've been using more and more. The important thing to understand, and Sri has already alluded to this already, there is some compromise in visual quality. So if you defocus the non-dominant eye too much, so for example, if you go minus 1.5 or beyond, there will be a reduction in visual quality in the non-dominant eye. So that's where you have to be careful, and you may have patients who are very unhappy as a result of that.
Thank you for this comment, because I mean, that's very important to actually emphasize the idea that as soon as we manage a mini monovision, will induce some defocus, and at the same time you will increase the rate of halos. And by the way, maybe lose some potential benefit of EDOF lenses. So, I mean, we already mentioned many times that it's all about compromise.
I would add, if it's possible, a few comments. First, sometimes we still operate the patients with a transparent lens because there are high hyperopic patients when we cannot do anything else, and they're really suffering with thick glasses, and which are changing very often, and decreased distance vision, and we have a risk of the glaucoma. So there are still medical indications to reflective lens exchange in these cases. And regarding the myopic patients, I would say also support your opinion that they of course have an excellent near vision, and it's very important to teach them at which distance they will see after the surgery, because they don't understand that they will not see here in front of the nose as they did before.
That's a good point. Patient education. Joaquín, you want to make a comment on that? It's very important.
Yes, it's very interesting, that point that said Erika about the therapeutical indication of a very shallow anterior chamber. It's very interesting, this is true. But we need to take advice about that. Probably in a very high hyperopy, we are going to lose one line for distance when we compare corrected in glasses with compare with intraocular lens. So we need to take advice of that. A very high hyperopy, when they see with glasses, they can reduce one line in comparison with intraocular lens. It's very important because there are a lot of patients with very high hyperopy. They could have some time of amblyopia, and we need to take advice, be very careful with that. But I absolutely agree with Erika that the therapeutical indication, this type of cases, is absolutely indicated.
We don't have all the available high power for the different kind of lenses that we previously mentioned. But if we do have the good power, I would recommend to prefer EDOF rather multifocal, because for all the reason that Joaquin mentioned, and in top of it, we know the difficulty to provide a good quality of vision for these eye ametropic patients, whoever they are, eye myopic or eye hyperopic. So, I mean, we have, again, this trifocal and EDOF. Inside of this category of EDOF, we know that there is one main goal that we can call the social vision, which is basically this range of intermediate vision. And we know that, I mean, it's a goal, but we do have different concepts. So for our auditors, can we maybe specify in your daily practice how you make a different interaction for EDOF compared to trifocal? If there is a place for mixed matching, maybe some concept. Who want maybe to start? Maybe we can start with Joaquin, just to change the turnover of discussion. Yeah.
Yes, when we have right now this cutoff of OC of 1.5, we go directly for the algorithm of the pseudophakic procedure, okay? And we really prefer, because in the main patient of our sample in the clinic, they want to avoid reading glasses, any glasses, okay? So we used to implant trifocal lenses, first of all, okay? But of course, we need to know what's the behavior of the patient. We are using some questionnaire for know exactly what are the behavior, but we use also the video with our patient in order to know the distances of any task. Also, the illumination that I used to know. For us, is very important, the pupillometry, and what are the importance of these photopsias in their life, okay? If we have a patient that could have been affected a lot with these photopsias, of course, we are thinking about EDOF lenses, probably a refractive EDOF lenses that have, we have evidence that the refractive EDOF lenses can reduce the tips photopsias, okay, in comparison with diffractive EDOF lenses. But we prefer in the main patient, the trifocal lenses. We have published a long-term outcomes with the ATELISA 3, 6 years of follow-up is the longest follow-up with a trifocal lenses, and the satisfaction is absolutely amazing. That these photopsias has reduced for the years, and our patients are really happy of that. So avoiding this patient that could have very complaints about these photopsias, we prefer trifocal lenses, but of course, it's a very demanding procedure in terms of not let any refractive mistake, very good surface, you know, all the things that we need to know with all the patients.
Erika, what do you think? I get that you share the idea that we need to achieve a metropia if we deal with trifocal lenses. Maybe the EDOF are a little bit more forgiving. So what do you think about it in terms of selection of
this is just what I wanted to say, that there are different clinical situations we have. And of course, there are patients with a slight astigmatism on the cornea, priori treated patients with a corneal refractive surgery. And in a case we have some luxation or subluxation of the lens. So there are 3 situations when we are challenging, because the centration of the trifocal lens is also very important. And this 4th topic is the expectations of the patients. Patients want everything. They want to have an excellent distance vision, no halo, no side effects, and they want to have a near vision. And we have a very good experience of a mix and match. And if we have a chance to detect the dominant eye of the patient, then it's a possibility which we try to use. So again, EDOF lenses, if it's possible, refractive lenses, in cases of operated corneas, in cases of a slight astigmatism, and if clinic or the hospital has a possibility to have a reserved lens. So, for example, we are planning a trifocal lens, but intraoperatively, we see that the capsule is not stable enough. So it's probably a chance or a way to replace this lens with a EDOF lens to provide the patient better result, especially if we need a suturing of the lens.
So what do you think about this aging population, patients who are candidates for a true cataract? Do you think that because of the, again, the aging process changing a little bit the contrast sensitivity, do you think that it's maybe a better place for EDOF compared to trifocal for this old patient?
Yes, and I think it's also the question of the possibilities of the brain adaptation. And of course, unfortunately, it's reducing within the age. And EDOF lenses are accepted by the patients much more easier. So I think it's the first probably choice in these cases, especially if the expectations are not very high.
Questions to you, Joaquín. I mean, you have this great study reporting on a 6 years follow-up. So maybe you can answer on these very common questions. What's going on if and what will happen if there is any retinal complication in the long term. Do you think that we will have maybe to remove the trifocal lenses? How we will manage it? It's quite a common question that we are all, we have all in mind for the future.
It's an excellent question, Beatrice. I think, first of all, we're talking about a lot of things. We hear for a lot of colleagues about decision, but I think we need to improve our decision based on evidence. Okay, sometimes we take some decision based on plausibility, in hypotheses, in possibilities, even in theories coming from the optical bank. But we need more and more, as I told you, trials with control groups that in a very solid way tell us what are the best option and not based on hypotheses. Okay, coming from answering your question, that's right. This is a very good question. What happened in the long term if this patient they are going to have a longer life could have any loss of contrast sensitivity? For sure, we could expect that the focus with less light distribution is going to be reduced as long as the contrast sensitivity is going to reduce. Okay, we need to tell to the patient this situation. Okay, but the key is in the distance vision that the majority of the lens is going to have the highest light distribution. Is going to be very low in comparison with a monofocal that could indicate an explantation, a reshape of the lens. This is a very interesting point. We don't have answer coming from the evidence. We only could have some hypotheses from the optical bank, comparison the MTF of the monofocal with the multifocal. And right now we need more and more evidence of that. Very recently have published a paper in this type of patient in glaucoma and retina, and with this very little evidence can tell us that probably could be affected the defocus, the deep of field instead of the visual acuity. Probably it's not affected the visual acuity in the distant vision, corrected. Probably it's, but I couldn't read in the paper the contrast sensitivity. Probably is affected in the contrast sensitivity, but we need these two group, this control group, to verify that we need, if we need a rechange of the lens or not. But of course, this is a very interesting field for some type of lenses that could be very easy explanted. I don't know, like a PG bag or something like that.
That's an important point. So, I think that we need also to consider a new ingrowing population, which is these patients who have been operated in the past with previous corneal surgeries. So it's now a part of our daily practice, I would say. So tell us about the keys and some tricks about the proper calculation, which lens you would prefer for these kind of patients. I would like very much to share your experience on that, because I think that for most of our audience, it's something that, again, it's a key question.
So a lot of measurements first, and checking the proper data, and avoiding the dry eye. A lot of different formulas and calculations and comparison the results. And of course, the IOL master is a main device we have, but still we are using other formulas and comparing and searching for the mistakes to avoid it. If we have a lot of patients with radial keratotomy, in Russia, and this is another challenge because the cornea changed dramatically, and here we never use multifocal lenses, we use monofocal, unfortunately, and we try to move the possible mistake in the myopic direction to be able to adjust afterwards. But still, if we are talking about the changed cornea, I would prefer the EDOF option and not a multifocal option. So this is a question, like Joaquín said, what we are never doing. So never multifocal lens, especially with the mixed optics, refractive, diffractive, for example, in a changed cornea, because it brings unsatisfaction to majority of the patients. This is our experience.
Let's talk about this risky population, patients at risk for macular disease, for glaucoma. If everything is stable, if it's just a family risk factor, do you go, for either, even for multifocal lenses? Sri, what do you think about this, I would say, patient at risk with no disease at the time of the surgery?
Well, there are two categories. One is those with clear lenses who have the pathology, like early age-related macular degeneration. And if they are in their 50s, I would still like to do presbyon, because once you remove the lens and put an intraocular lens, then the progression of age-related macular degeneration is much faster. And if they have clear lenses, then I would probably not use a multifocal or a trifocal, just opt for presbyon. And in those patients with a stable pathology, I would again discuss with my retinal colleagues who are treating them, because most of the retina colleagues do not like a multifocal lens because they are not able to focus clearly. They are not able to take good photographs of the retina. And if they want to give any laser treatment, again, that's also a little difficult. So if they have any retinal pathologies, I would like to kind of discuss with my retinal colleagues and then go ahead if I'm going to put in any of these premium IOLs or multifocal IOLs.
And so, Amir, what do you think about the long-term complications? Patients who have a multifocal lenses and who will finally later on see any retinal complications. Do you think that we will have to remove these lenses? We do have a significant now follow-up with these multifocal lenses, and so do you think that we may have to manage this kind of situation in case of late complications?
I think that's a great question, and something that we, to be honest, despite having a long follow-up on, don't really have the data to really give a good answer. It's certainly possible that in a small minority of patients that would be an option that we would need to take, but there are also a larger group of patients where it may not be such an issue. A lot of my vitreoretinal colleagues are now themselves quite comfortable using diffractive multifocal intraocular lenses, and therefore much more comfortable, examining these eyes and treating should there be any pathology. We have seen, for example, in rare instances where patients who've had cataract surgery or have had clear lens exchange develop, retinal detachment several years down the line, and our retinal colleagues are, able to treat them quite well with very good results. So, like I said, it's not well elucidated. I think we do need to have much better data on it. But I think as our practice evolves, I would think it would be less and less patients that would need to have such an extreme form of intervention.
We can also consider today, we are talking about delicate situation, but there is an ingrowing population. The patients who have been previously operated regarding whatever it is, radial keratectomy, LASIK, and we know that that's going to be the cataract for tomorrow. So do you have any recommendations for our colleagues, especially what we used to call the conventional cataract surgeon that shouldn't exist anymore? What kind of recommendations can we make for them in terms of IOL calculation, selection of the good lenses? Who wants to start on that? Sri, maybe you want to make comments on that?
Basically, there are a few tests that I would like to do for post-refractive surgery patients, and I would definitely do a topography. I like to do the pentacam, and I like to look at the EKR. I like to look at the EKR graphs and look at the distribution of the case to see if the cornea is regular or irregular. In irregular corneas where the distribution is not Gaussian, I would definitely not opt for a premium lens like a multifocal or a trifocal lens. If the distribution is Gaussian and the K distribution is quite uniform, then I would also look at the aberrations, corneal aberrations. And if the corneal aberrations are not very high, then we could look at a premium lens like a trifocal or an EDOF. Also selecting the correct formula is important. I basically use the IOL Master 700, and right now I like to use the Barrett TK True K TK. This is the new formula from Barrett, the True K TK, which is most accurate for post-refractive surgery, and it gives quite good results. But anyways, I would still warn the patients that since their corneas are altered, they may require an enhancement, a touch-up with laser if their results are not up to the mark.
What do you think, Amir? I mean, do you share the idea that multifocal is affordable when we know that you need perfectly to achieve the emmetropia in these cases?
Yeah, so I think it's I think the discriminating factor is you're talking to two refractive surgeons, so we will have a slightly different opinion to maybe our other non-refractive colleagues. But I think our appetite for implanting multifocal lenses for in post laser vision correction patients is there because we are quite confident with the tools that we have to hand to assess the patient's refractive status and also the latest generation formulae in conjunction with using the best lenses possible. So I do implant multifocal lenses in patients who've had previous laser vision correction. I treat them, as all refractive patients. So we do topography, aberrometry, and we use total keratometry with Barrett as well. We get very reliable results. What we do say is we do have to have, we have a set of rules that we adhere to, that they have to have normal topography, a high quality ablation, no irregular or decentered ablation, regular astigmatism, sufficient corneal pachymetry should we need to do a laser vision correction enhancement later. And again, as with anything else, like you've already alluded to, is that they have to have realistic expectations post-operatively. So that's the case. I think in terms of the other group, the majority of patients who may not want to have a multifocal lens, the patient's own corneal aberrations can be helpful to you as well. So you can choose a monofocal lens, which is aberration correcting or aberration neutral, and that in of itself can help enhance their depth of focus as well. So that's something else that we've been doing over the years to improve our results.
You can even again mention the use, for instance, of this EDOF pinhole concept that can be even useful in case of irregular cornea. So I think that we do have a full range of available lenses that can be, I would say, decently today offered to all these patients. And again, that's the cataract of tomorrow. So of course, I do address the same questions to you, Joaquín. Maybe, do you share the idea of doing an average, a mixture of different formula? Do you provide maybe a specific care on ocular surface? Because there is also a big issue behind these patients. And finally, do you share the idea of using EDOF rather than multifocal?
Well, we used to make an average of the ASCAR calculator for this type of patient. But recently, we have a very interesting paper published this year in Eye that when they compare is a group of Tucaneo, and they compare this formula specifically made for this type of patient, Barrett, Chukay, Haggis, and Chamas, and they compare with another formula, Evo, Haggis, Hover, Holiday, and SRCT, with the total keratometry of IOL Master, the percentage of patient around 0.5 dioptries, it was quite the same. So it's very interesting for this type of patient, the opportunity of using the total keratometry of the IOL Master 700, and we could probably improve in any formula our outcomes in comparison with this specific formula. And the other thing is the criteria for select this type of patient. I think we need to take very important, take care about the regular astigmatism in this type of patient. We used to use the pentacam. Maeda described a cutoff point of 0.5 microns for the 4 millimeters of astigmatism. We have some paper that demonstrate that above the 0.5 microns, the defocus curve reduced dramatically, but not below this 0.5 micron. This is very interesting. And the other thing is, what is the average of the spherical aberration with this patient? You know, when we measure the spherical aberration is for a big pupil around 6 millimeters in the pentacam, but it's very important to know exactly the spherical aberration for the mesopic pupil of the patient, not for the 6 millimeter. Probably the 6 millimeter spherical aberration, it would be very high, but the mesopic pupil of the patient is below, and we need to know exactly the spherical aberration for the pupil of the patient. And probably we could have a hyperopic treatment with laser, with not too big pupil that we could operate with any problem, even with trifocal lenses. But probably, as Erika said, EDOF lenses could be a good option not to get any problem with a very high demanded surgery like trifocal lenses.
We can even add that there are these, specific options like the pinhole lens that can be actually very useful in some irregular cornea, because we do have this kind of radial keratectomy that have induced a lot of significant irregularities. So I think that, that was a very useful discussion, and I hope that we gave some interesting elements to help our colleagues to manage the presbyopic patient. I mean, we know the number of presbyopic patients in increase, more demanding, and I hope that it has been, again, a useful and invigorating discussion. So I'm Beatrice Cochener again, and along with our panelists, Amir Hamid, Ganesh, Joaquín Fernández, and Erika Eskina, we'd like to thank you very much for joining us.